Hi there, I'm Lorna Smith. I work for Health Scotland, and I previously worked on our national mental health improvement team. And last year we were involved in the mental health strategy for Scotland being developed, which from a public health perspective was largely unsuccessful despite our best efforts of providing many of the references you provided today and conducting many consultations from a public health perspective. And ultimately, the mental health team within the government were pressured by the things that make the press and the things that the minister can say on a 4-year election cycle, as opposed to the long-term benefits. And our mental health strategy, as a result, addresses only early intervention and treatment and care. And the response was that, well, it's implicit that mental health improvement will go on by other sectors and in other policies. However, within those policies in education and parenting, in sport, it's also implicit. So my question is really, how can, as people who passionately believe in mental health improvement, and thank you for all your presentations, it was wonderful, how can we better articulate the case so that there's a shared ownership, but there's also leadership from the mental health workforce, which certainly in Scotland we're really challenged by.
Thank you very much. I actually wanted to ask a related question, so I just wanted to dive in there. Paula Ardilis from Canada. I've recently had the privilege of talking to a lot of policymakers in Canada who have been implementing a lot of provincial action plans. And what I heard from a lot of the very high-level policy decision makers is that they understand that applying a mental health promotion intervention has multiple outcomes that are long-term and that we don't necessarily measure, but there's also the benefit of being able to explain to another sector that the implications that, for example, a parenting program might also reduce level of unemployment for that if there's a single parent, that they might also have benefit in terms of unemployment, but they might also benefit in terms of the bond between the child and the mother, that they also might bond because they're more included in the community, because they can seek other services earlier, they have a higher level of education after they go through the program. So there's so many multiple outcomes from one intervention. So I guess my question to you is, how do you show that? How do you show the evidence? Because the outcomes are actually in so many of the other sectors. And so, it would just be wonderful to be able to actually demonstrate that to the decision makers, because that's what they want to see. They want to see that you're investing in mental health, but that the outcomes are multiple. So I just don't know where the field is at in terms of actually being able to show that cost effectiveness at that multiple sectoral level.
So thanks. Yeah, maybe if I just sort of respond to the question about the difficulty of implementation. I think I spent several years at the UK's England Department of Health putting together the evidence base, and then I slightly naively thought that if we could get all the evidence base into policy and say all the right things, then everything would happen. That's not the case. What's required is, I think, consistent and continuing advocacy from a broad range of stakeholders, not just within health, but particularly the third sector voluntary organisations who've been very powerful in the UK lobbying. Despite all the great work that David and colleagues did from the LSE, we've actually, and also a very clear evidence that it's only a minority of people with mental disorder get any treatment, and there's virtually no spend on promotional prevention. Despite all the returns, we've actually had a reduction in our mental health budget in the last year. So I think there's something then to be said for, well, actually, we're looking at a slightly more difficult issue, and I think Prawett's kind of example of localism is very interesting. I sort of highlighted some guidance, and I've applied that locally to a region of 700,000, and then showed different local sectors within that area the costs of mental disorder. And now they're seeing, for instance, the cost of conduct disorder each year. A one-year cohort of children and adolescents with conduct disorder costs £800 million. That's the lifetime costs. And actually most of that is hitting the criminal justice sector. So there's something around national policies which are quite difficult for people, stakeholders to apply. I think Prowett's example of actually take-up and almost kind of mainstreaming from the grassroots up is a really nice example, and I think applying pressure to your local politician through, for instance, the transparency argument, well, why is it only 10% of people with drug dependence get any intervention, and look at the cost of that. So there's something about slightly turning it around. It's been my own experience because I was quite disappointed having spent, as I said, all this time. But I think it's also a consistent message to an engagement with a broad range of stakeholders that sometimes people in health they're not so good at doing. And so I'm working with the public health department at the moment, and I've learnt a lot. And I've just been aware also that their knowledge about mental health was actually quite limited. And so we've both learnt a tremendous amount, and through that engagement, I think we've got. But it's kind of more local level, but then using those examples to inspire nationally. So, but maybe if I hand over to David about the savings across a broad range of sectors.
Yeah, there absolutely are ways of doing this. Now, if you try and simply report cost per quality adjusted life year or disability adjusted life years, it doesn't really get covered very well. But what we tend to do, because mental health is messy, but this also applies to complex interventions in general, is we try and report separately the impacts and different outcomes, whether they're health, whether they're social care, education or transport. We report them separately and we leave it up to the decision makers to decide on how important those decisions are. I mean, you know, obviously some will have more importance than others, but if we were making an argument to an education department, we would absolutely focus on the education arguments. We'll be looking at school attendance, school performance in the regular tests that people have, the impacts on classroom disruption. We'd make sure that we would, if we're doing an evaluation, we would make sure we'd be capturing that kind of information in addition to the things that we may be more interested in terms of mental health. But there never will be one composite way other than doing something called cost-benefit analysis, which is trying to put a monetary value on everything. But that has disadvantages as well as advantages. One other thing just to say, to come back to the point on how to get things to happen, this is probably not very helpful, but actually money can help as well in the sense that if you have some shared budgets for some shared common objectives, then everyone has a responsibility for the money, and everyone can feel, hopefully, the benefits of doing more with that money. There are some examples of where that's been done. For instance, for people who have both mental or back-related problems that keep them out of work, you can have a shared budget for the mental health department, the social security and welfare department, and the work department to try and develop an approach to helping people return to work. So it is possible to do these things, and sometimes it's practical things. In Scotland, probably all these people work fairly close to each other geographically because everything's in Glasgow or Edinburgh, basically. And so there may be ways of actually co-locating people a bit more easily so they physically meet each other more often and actually start having dialogues as well. Because I know our colleague from Scotland was complaining about the Scots system, but it seems to me the smaller the country, the more chance there is of something happening, which perhaps also links to this localism business, because an example we didn't mention today, but very fascinating, is what's been going on in Iceland. Now, Iceland's a very small country, 350,000 people, but they've had a huge focus on well-being and happiness. They developed a kind of mental health first aid approach to dealing with the economic crisis, which really hit them very hard indeed. And their mental health outcomes are pretty positive, actually, a few years after the crisis. And, but what they could do there may not be done in a larger country, but it might be done in a county or a region of a larger country. And I think it's also vital, the grassroots, the community, the volunteers getting on board as well. In the UK, we're quite lucky because we have quite active non-governmental organisations, which I know is not the case everywhere, but that's another important thing. faith groups can also help as well with these kinds of things, or other community groups. I know we're really over time. Robert, do you want to add anything at all? Does anyone have any last question at all? Because I thank you for your patience because we've overrun, but I hope you've found it useful. Any last burning questions? Any comments? Or you're all desperate to get out of the room?
Could I just add something, maybe just as a last acknowledgement really of the Thai Department of Mental Health, because I think I think it's just such inspiring work that you're doing here, and certainly I've learned a tremendous amount, and also to acknowledge your tremendous generosity as well. I mean, we're here and very pleased to be invited, and so thank you very much for both inviting us here, but also to share and learn from fantastic work going on in Thailand.
Absolutely. Thank you.